Hi, it's Dr. Centeno, and thanks for joining us today. Interesting topic. I have a lot of patients where I perform a telemedicine evaluation for craniocervical instability, and um, the patient could be doing things at home to help decide if their symptoms are coming from CCI. Now, a lot of times I'll explain what they can do over a telemedicine evaluation. So I thought if I did a video on this, it would help a lot of people get that information before we do a telemedicine, or they'd have some sense of what it is I'm talking about, because it wouldn't be the first time they've heard that. So we're going to go through that today. 5 things that you can do at home to try to decide if your symptoms are coming from CCI or craniocervical instability. So let's see here. I'm going to go ahead and share my screen. And we'll go to today's presentation. So again, going to talk today about top 5 ways you can help diagnose CCI at home. I'll start with a simple discussion, go through this whole presentation, and then we'll turn it over to the floor for questions. You can ask questions about this or really anything you would like. So the top 5 ways you can help diagnose CCI at home. So diagnosing CCI on an MRI is almost always a bad idea, or really any imaging study. So what I mean by that is that I'll see a lot of patients who are convinced that there's something on their MRI that shows that they must have symptomatic CCI. And many times a surgeon has told them that and then decided that they needed super invasive fusion surgery solely based on looking at that picture. So one of the reasons why we're getting into this top 5 ways that you can diagnose CCI at home is because there's no validity to that approach, meaning that there are patients out there who have findings of CCI on imaging but no symptoms. So please, if you learn nothing else today, it's that nobody can look at an MRI, especially for the kind of CCI we're discussing here, meaning we're not talking about the kind of CCI where someone gets into a car crash, they go into an ER and someone determines their head is falling off and they need emergency surgery. So looking just at your MRI is not a valid way to determine if your symptoms are being caused by what's seen on that image. So make sure that you understand that take-home message, that there's more to it. And we'll go over some of the things that define the more to it. So getting a diagnosis of symptomatic CCI takes other pieces of the puzzle, right? It takes more than just imaging. We need to look at things like response to treatment. We need to look at the symptoms, the cause, a hands-on physical exam. All of that produces a puzzle that allows us to see the underlying picture and say, yeah, this person probably has symptomatic CCI, or no, this person probably doesn't have symptomatic CCI. And the goal of this video is to teach you how to do things at home, which will help a super specialist physician get to the bottom of whether CCI is causing your symptoms or not. So these are the top 5 things to do to rule out CCI. One is a simple cervical collar test. Another is just observing your symptoms to see if they are in fact neck related. Getting a DMX, which you can do really without a prescription. You just walk in, pay your money, and get a digital motion x-ray done. You don't, again, like I said, usually need a prescription for that. Response to treatment, and then deciding if there's a cause and letting the doctor know what that cause could be. So a cervical collar test, and this is probably the one I recommend the most on the telemedicines that I do, and that is, does locking out your neck reduce your symptoms? So how do you do this? Well, soft collars are usually what I recommend. You can go on Amazon and buy a simple soft cervical collar. It's not going to cancel out as much motion as a hard collar. But the problem I see with hard collars is in some patients, the hard collars put too much pressure on specific areas that then end up causing new symptoms. So if you had to guess which one is going to get you to the conclusion of whether or not locking out the neck reduces symptoms, a soft collar is more likely to do that. Now, you can try a soft collar. If that doesn't work, you can always try a hard collar. I discussed with people that these things are so inexpensive on Amazon, you can certainly cut it here and there to make sure it fits correctly. But all you're trying to do, again, is to wear this for a couple of hours for a few days, and then just take notes on what your symptoms are like with the collar on and the collar off. And you're trying to see if there's a noticeable decrease in symptoms when you're wearing the collar. If you've got a major improvement in symptoms with the collar, then I wouldn't recommend using the collar all the time, because that will weaken your neck muscles, which also provides stability. So basically, if you really like the collar, regrettably, you can only use it intermittently. So that might be things like car rides or long trips on a plane. But you wouldn't want to use it all the time, because if you do, that'll lead to muscle atrophy, which will end up making the instability worse, not better. Symptom observation. And this is a pretty simple one, right? Do your symptoms increase when you use your neck? For instance, head turning, flexion, or extension. So for example, if you turn your neck and your dizziness gets worse, then that's an important thing I would need to know. It would also be good to try, instead of doing this, try doing this a couple times and only moving with your thoracic spine, and see if that still causes dizziness. And in particular with that symptom, that's helpful, because obviously dizziness can also be caused by the inner ear. And whether you turn your body or your neck, the inner ear gets fired off. But if you just turn your neck and you get dizziness, and you don't get it when you turn your body, then that really helps me decide, yeah, there may be something going on with the neck here that we need to take a look at. Another one is get a DMX. As I've always said, if we're going to rank all of these different types of imaging, DMX is a good one, because in general, it tends to be more likely to identify CCI if CCI is present. Obviously, you can also get there on an upright cervical MRI with flexion extension views. In my experience, a little less likely to identify CCI if it's present, but still pretty good. You can also get there with other types of imaging. The reason why I bring up DMX is you usually don't need a script. It's usually a cash and carry procedure anyway, so you're not trying to get insurance approvals for it. And many DMX centers will just do a DMX on you if you just call them up. So you usually don't need a physician script. The good news about DMX is that they generally all follow a specific protocol, so you don't need any specific instructions from me. The only caution I would have is be a little careful. In my experience, many of the DMX centers tend to overread these. So I'll want to take a look at the actual image to make sure that we can get to an accurate conclusion about whether or not CCI is present and what the measurements on that DMX probably are. Another simple one is response to treatment. Now, the best I can do here is to say what the common CCI response is. Obviously, not all patients with CCI respond in the same ways. So, if we look at the common CCI response, things like NUCA, AO, upper cervical chiropractic tends to help. Less common that it makes things worse. Caveat being, sometimes we don't see, or sometimes we see providers out there that aren't using the proper adjustment vectors. So that could also make things worse, meaning that upper cervical chiropractic may have helped if it was the right type of adjustment. Active physical therapy, again, commonly will make CCI patients worse. Botox injections tend to make CCI patients worse because you're reducing that muscle stability, because Botox works by weakening the muscles. And simple ligament prolotherapy will often help make CCI patients a bit better. Now, realize again, caveat there is that if you've got more internal ligament problems, it may have no effect at all. So that one's a little bit more iffy than the first three. And then finally, why do you have this? Is there a cause? The known CCI causes are trauma and hypermobility, EDS. So one of the things I often recommend to patients is think back. Did you have some head and neck trauma? And many times patients really won't remember it, but they may say, oh, wow, yeah, now that I think about it, 20 years ago, I did have a pretty big car crash. It took me weeks to recover from that. I hit my head on the pickup truck back window. Never really thought too much more about it. So that's a good thing to do, is to think back into your past. Is there some significant trauma in your head and neck that you can relay to the doctor? So in summary, there are things you can do at home that are fairly simple that will help me decide if you've got symptomatic CCI. Obviously, they'll help you decide as well. So thanks for watching that. We're going to go now to some questions. Let's see what we've got here. We got a whole bunch of questions. So we'll go to those. Dr. C, you said in the past with CBB, you were stretching certain ligaments that you want to have stretched for curve correction. What are those ligaments? Yeah, the biggest ones, AT, would be the ALL in the front, and also not only those ligaments, but the longus colli and longus capitis muscles. So those are the biggest ones getting stretched with most types of simple curve correction. And then AT again. For nerves that have been injured, causing muscles to shut off and atrophy, are there any supplements can help stimulate and restore function? Not that I know of, no. Maya. Hello, can Arnold neuralgia mimic cervical instability, or maybe Arnold-Chiari syndrome? Can you tell us more about it? Yeah, I think we're talking about similar things. So Arnold-Chiari syndrome is where the brain hangs too low in the skull case, basically. Now, there's lots of different types there. There's a CTE or a type 0. The problem with getting diagnosed with a type 0 or CTE is that there's lots of people walking around that have CTE and they have no symptoms at all. Then we've got type 1, where the cerebellar tonsils are more than 5 millimeters below the foramen magnum. And again, there's people walking around with type 1 who have no symptoms. And then we get into the types of Arnold-Chiari that are usually operated many times in kids, where you've got a type 2 or type 3, where you've got a lot of herniation of the cerebellar tonsils coming down. And those are usually associated with pretty significant symptoms. So the question is, if in a type 0 or type 1, a lot of people don't have symptoms, how do some people get symptoms? Well, it's believed that some people get symptoms because of cervical instability. So that's when I said that these topics were connected. They're connected in that way, meaning we often see Chiari 0 patients, and maybe if they didn't have the Chiari 0, i.e. a slightly low-hanging brain in the skull base, they wouldn't have any symptoms. And it's instability plus Chiari equals symptoms. Chiari with no instability, probably no symptoms. So it's important to understand that Chiari is not this static concept. You don't have it and then have symptoms. You have it, and for the most part, it doesn't cause any symptoms, but you can develop other problems that plus Chiari can give you symptoms. Bo, I've been suggested to need at least 2 PICLs. What's the maximum amount of months that I can go before my second procedure before it will start to reverse with wear and tear? Yeah, Bo, we had this experiment happen during COVID. It was kind of a natural experiment where we had patients that couldn't come in for anywhere from 9 months to a year and a half. We had about half of our patients reverse their gains, and about half of our patients keep their gains. So it's not a sure thing that you'll reverse your gains, but in general, we'd recommend a 4 to 6 month time frame, minimum 3 to 6 month time frame in there before a second procedure. That one was, Bo, is it common for CCI patients to experience a lot of pain like inflammation all over the neck after nuca adjustments that last for 1 to 2 days? Yeah, I would say that as long as you're getting to the other side of that, meaning that you may have central sensitization then, and as long as you're getting to the other side of that, that's good. Meaning that you probably know that you've got a little bit of that fragile leg syndrome going on, central sensitization, pissed off nerves. But if you're getting to the other side of it and feeling much better after that 1 to 2 days, then I think you're headed in the right direction. If all it does, however, is to piss it off for 1 to 2 days, then you may not have the right vectors, or it may not be a good fit for you. Regenetics been advanced by Christy. I'm wondering if your diagnostic criteria, DMX imaging for 1A instability differs in EDS patients compared to non-mobile patients. If so, how do you account for this in your hands-on assessment? Type 1A. Yeah, so normally in type 1A patients, we can see some of that on DMX. That's one that's a little bit better and sometimes clearer seen, especially in hypermobile patients, on an upright flexion extension MRI. As far as what do we look for on physical exam, it would be, in particular in that patient population, quite a bit of tenderness and reactivity in the rectus capitis posterior minor posteriorly. Ryan, have a pressure feeling right at the top of skull internally, and also very sore skull tender to the touch externally. What are the likely causes of this, and is it damaged irritated nerves causing this? Well, internal pressure sensations can come from everything from intracranial hypertension to just swollen bursas inside the head, to swollen facet joints at 0, 1, 1, 2, or 2, 3. As far as external tenderness and soreness, where your skull kind of feels hypersensitive to touch, that's going to be more irritation of either the one of the greater occipital nerves, lesser occipital, or third occipital nerve, or the C2 dorsal root ganglion. So that's all more nerve-related stuff. In nerves that go to the skin of the head. AT, for patients who are able to restore their curve, how often is it recommended to get a PICL to hold the curve after? There's been a concern amongst PCI patients that curve won't hold if restored. Well, so if you're not holding your curve, then there's some damaged ligaments. So that would be a case for doing and tightening up the supraspinous, interspinous ligaments. It doesn't really interface very much with a PICL other than increasing the curve, or generally take some weight off of those upper cervical ligaments and may make it easier for those ligaments to heal. Obviously, if you can't tolerate curve restoration, then you've got to get those ligaments tight before that person can tolerate it. Criminology, most collars are 3-inch, and worse afterwards. A 2-inch collar feels great for driving, but I can't find one. I had to cut down a foam collar. Yeah, so all I'm trying to get is information that wearing a cervical collar helps, and it's okay to buy an inexpensive one online and cut it down if it doesn't fit your body type. Really, all we're trying to get to is information there saying, if I lock out the neck with a collar I buy online, or maybe a collar I buy online and modify, then that seems to help me, because that's an important piece of information for me in trying to determine if that person has symptomatic CCI. Adina, what is your opinion on styloid C1 transverse process? Juxtaposition isn't necessarily symptomatic. No, not necessarily symptomatic at all. Meaning that lots and lots of people with long styloids have no symptoms. That's been well published in the Eagle syndrome literature. In fact, the minority of people with long styloids report Eagle-like symptoms. So having long styloids doesn't really tell us much, since most people walking around out there with long styloids have zero goose egg symptoms. Generally, again, we're in that same place here where we were when we were talking about Chiari malformation. Long styloids could certainly be causing someone, if they get C1 or C2 rotation, to have nerves that get banged into because there's upper cervical instability. But long styloids by themselves are pretty meaningless in trying to determine if someone has Eagle syndrome. Regenetics, it's been advanced by Christie. Have you noticed a correlation with instability in the neck and weakness in the rest of the body? For example, prior to my neck injury that caused my AAI, I couldn't do lateral pull downs or deadlifts without flaring my neck. After my first PSL 3.5 months ago, I could do 130 pounds for lat pull downs, 135 for deadlifts, which is great. However, I can't tolerate basic exercise on my back, like dead bugs or lying on my back. Just wondering if this is... Yeah, so I often talk about this, Christy, in the context of a rowboat. Let me explain what I mean by that. So let's say you're going to go and you're going to lift 135 pounds in a deadlift, right? And you do it on the shore on a stable base. No problem. You do your 135 pounds. You did it right. You did it with good form. Felt relatively easy. Now, you take those weights onto a rowboat, and you go out into the middle of the lake and you try to do the same deadlift standing in the middle of an unstable rowboat. It'll be almost impossible to do. Or at the very least, if you're extremely fit, it'll be very much harder to do. Why? Because your muscles are now not only focusing on lifting the weight, they're focusing on trying to stabilize you to make sure you don't tip over in the rowboat. So it's the same thing with CCI. You've got no solid connection up here. So using those arms and other parts of the core become more difficult because you're not lifting those weights on the shore. You're trying to lift those weights in the middle of a rowboat that's unstable. Maya C, what causes occipital neuralgia? I was told by the doctor that I might have Arnold Chiari, and that irritates my nerve on the right side behind the ear. Should a doctor diagnose that with no MRI? Occipital neuralgia is usually caused by the occipital nerves here overworking and would have little to do with a Chiari malformation. So those two things are usually not connected at all. So no real connection between the Chiari malformation and occipital neuralgia. EV Tech, should patients use posture pump for curve? That's a good question. I think that there's certainly patients out there who could benefit from posture pump. Just so that everyone understands, posture pump is a specific product out there where you put it behind your neck and you kind of pump it up. It can be fairly aggressive in my experience. I've tried it myself. I couldn't tolerate it personally. So I think the first thing to do would be seeing if you could tolerate just a rolled up towel, put back there, lie face up on it, experiment with how thick the towel is, and see if that's a net positive for you or a net negative. Now, then if I could tolerate that, I'd probably see a CBP specific chiropractor and then ask them if they think a posture pump is a good idea for you. Kimmy, I was put on prescription vitamin D. I'm assuming it's okay to start taking. Just want to make sure first PSL number 1 is in 3 weeks. Yeah, not a problem, Kimmy, to be on prescription vitamin D. EV Tech Insider, how long to rehab the vestibular system after PICL? Is it normal for you to feel strange because your head is in a new place? I'd have to know more about what you mean by rehab of the vestibular system. Normally after a PICL, we want patients to be asking their treating physicians about whether or not they should do X or Y when it comes to rehab. So I'd probably have to refer you back to the treating physician to make sure that that's appropriate for you at this time. And if I were the treating physician, I would ask, give me more detail on what kind of rehab you're planning on doing. Regenix, it's been advanced by JB. Does PICL procedure treat vagus nerve issues if you also have CCI? If not, what can treat vagus nerve issues along with upper neck issues like out of control formation, emotional instability? We also treat vagus nerve issues as part of PICL. So I think that answers that one. AT, for type 1C, if the ALL is the major ligament that needs to be tightened down, that wouldn't be a 1C. Why would you want to stretch it out? Yeah, so not 1C there. So ALL would control C2-3 on down. Above the atlas, you're going to have different ligaments, including the AAOM and the tectorial membrane. The tectorial membrane is what the ALL would be farther down. Or the PLL, sorry. ALL would be the superficial ligament there between the atlas and the skull. So not ALL. When it comes to curve restoration, we're really talking about trying to stretch the ALL in the middle here at around C4-5, C3-4 would be the maximum stretch, not those ligaments that are above the atlas. Vicky, how long does PICL help with bulging discs, or how does PICL help with bulging discs and herniated discs? We would also treat that issue. Now, bulging discs are not a problem unless they're irritating nerves. And the problem is usually not the bulging disc, the problem is the nerves. So the treatment there would be platelet growth factors around the nerve and also trying to get rid of the degenerative instability at that level so that the nerve isn't getting banged into. It's been advanced by Harry Winston. Any chance of making an appearance at Algo Cells this year when you head out for your early trip? Probably not. I usually go through London because it's a direct flight from here, but not there for very long, just a day to visit my niece who lives in Cambridge, and then we head out. So probably not. AT, thanks for your time, Doc. I was also wondering any further updates on Dr. Katz or Dr. Rosa. Yeah, thank you so much for asking about that. They both agreed to do it, which is awesome. So Sherry, my scheduler, is trying to find time on their schedule in this time slot. And I wanted to have them on here live so everyone could answer or ask them questions and get answers directly from them. I thought about just recording a session with them and then doing Q&A. But I think it'd be better if you guys can ask direct questions to Rosa and Katz. So that is now in process. And thank you so much. I'm not sure if it was you or someone else who recommended that, but that's a good one, a good recommendation. Thank you. Is internal vibration a sign of CCI? I notice, especially when lying down. It can be. I have heard that before, but it would be a less common CCI type symptom. Ryan, I have irritation in the legs and feet, almost like an overactive nerves vibrating feeling that is usually worse at night. This is because my cervical spine more likely coming from problems in the thoracic lumbar area. Yeah, most likely coming from problems in the lumbar or low back area, usually. And I too have had that overactive nerve vibrating feeling in lumbar nerves. So I feel you there. I understand it because I felt it myself. Jigesh, does nasal Flonase for allergies affect PICL? Yeah, Flonase is a corticosteroid, so we generally don't like patients on either inhaled or nasal corticosteroids for a good 6 to 12 weeks before a PICL because it will impact overall stem cell function. We know that based on the published literature. EV Tech Insider, do any patients 100% heal? Sure, we've got patients that return to 100% full function. As I always say, that often depends on the depth of the hole, meaning how severely disabled the patient is when we start, how long they've had this, how long they've had that disability, how many other swirling around diagnoses are intersecting with CCI, all of that good stuff. Bo, my NUCA adjustments slip out by 1 to 2 days. So with having inflammation pain for the 2 days after, and then have a different pain from being unaligned. Are there any other options, or with NUCA? So it doesn't sound like, Bo, you're getting a lot of relief from NUCA. So if it's only really causing things to get aggravated and then a new pain, I'd have to question whether or not it's a good fit for you. Elving Anders, if you have CCI, is it common for delayed exertional aggravation, such as headache the day after exercise, to be milder if you drink alcohol or take muscle relaxers such as benzodiazepines? Usually, well, I guess the question would be when you took those. So a lot of people that take those, for instance, it's a pretty common thing in instability patients. You go have a couple drinks, maybe go dancing or do something you don't normally do, and then you pay for it the next day. So things get loosened up, you're moving around, you're feeling no pain, and then the next day you feel it because all of that instability causes inflammation in the joint that then rears its ugly head the following day. As far as whether or not after you have those symptoms, will alcohol or muscle relaxants like benzodiazepines make it better? It certainly can. But that may also cause a little bit of a vicious cycle, because then it'll cause things to loosen up a bit, a little bit more trauma, and then the next day, symptoms. Kimmy, what do you think about adjustments to the sphenoid bone? Could it be helpful? I just heard about this recently. I'm interested in your opinion on it. Kimmy, that's more craniosacral type treatment. By all means, I'd give it a try and see if it's helpful. Jingesh, would you recommend a second PICL at 3 to 4 month mark? I had one done on 12/18. Would you recommend doing DMX to check for improvements prior to proceeding for a second PICL? Jingesh, normally what we would recommend is we would take you out till about March, let's say, beginning of March. We would see where you are at that point. If you're reporting significant improvements, then we would give the thumbs up for a second PICL. If you didn't report significant improvements, we could always look at a repeat DMX to see if we made progress, which might help inform us as to whether or not a second PICL makes sense. EV Tech, can CCI cause my teeth to feel strange when my symptoms are bad or I move wrong? They feel like they're out of place and I can click them back into place with my tongue. When I use posture pump, they feel like they're falling back into place, push backwards, and don't click anymore. Yeah, so I think what you're describing is more the mandible or the TMJ being unstable, which is pretty common in CCI patients. And if increasing the curve tends to make that jaw instability better, then I think that's good, especially if you can tolerate that. Any other questions out there right now? Today, again, we talked about the top 5 things that you can do at home to try to help a doctor clarify whether or not you've got symptomatic CCI. And happy to answer any other questions that are out there if we've got any. I do have a 2 p.m. on my side meeting, but I do have more time. If you've got more questions, happy to answer them. Sometimes I've heard that questions don't come through super quickly on this app I use called StreamYard, but happy to answer any of those if they're out there. Looks like I think we're running out of questions. So I'll start wrapping this up. I want you all to have a great weekend. Thanks so much for watching. Thanks for the great questions as usual. Again, we were talking about the things you can do at home to diagnose CCI. Jingesh, do you inject ligament and flavum during PICL? Yes, if it needs to be injected, it gets injected for sure. Okay, guys, you all have a wonderful weekend. Again, thanks for the great questions. I will Yes, I will be here this coming Friday, and then not here the Friday after that because I go to our Grand Cayman site and I don't get to do this down there. Rishi, why do doctor continue to use steroids so much, not platelet lysate for nerve injury? Yeah, it's a good question. It's getting to the point of almost malpractice now, given that we know so much about how steroids damage tissues. I think the answer is it's covered by insurance. There's not really much institutional momentum pushing back against it, and there's a lot of institutional momentum pushing in the direction of using corticosteroids. But you're right, they shouldn't be used on a regular basis at this point in 2024. Aaron, can CCI cause CNS damage? It can, yes. Can Anavar and growth hormone help after PICL? No information to inform that. I can tell you that we did a growth hormone, HGH, in vitro experiment many years ago, probably 12 to 13 years ago, where we took bone marrow mesenchymal stem cells in culture. We added in human growth hormone. We only saw about a 15% improvement in proliferation of the cells. So it really wasn't enough for us to want to adopt using it in patients. Then EV, I see athletes taking this post-surgery. Yeah, athletes take all sorts of crazy stuff. So I wouldn't have them be my guide, basically. I think they're more likely to take scary stuff than helpful stuff. AT, any correlation with true lower leg discrepancy and having a larger overhang on that side of the neck and fixing that, take tension off the side, help it heal? I think what you're talking about is dealing with side-to-side scoliosis, which can certainly help take pressure off one side of the neck in lateral bending. So a good way to do that, if it's as simple as getting rid of your leg length, meaning it's really more about aligning the pelvis, then that's a good thing to do. Also, you can look at SCROTH, S-C-R-O-T-H physical therapy, which can help strengthen the patient side to side and get them more balanced, especially when you have a scoliosis or a side bend. Lady Cap, several MRIs, no issues. All symptoms go away when lying flat. Can that mean CCI, severe headaches, blurry vision, neck pain, shoulder pain, facial pain are some symptoms? It may. You may want to go back and watch the beginning of this. That'll help you try to get to a symptomatic CCI diagnosis. And then obviously imaging would be the next step. Bo, a week is about as far as I can tolerate without or with the unalignment. So that's why I go. When you say Nuka, okay. So it sounds like, Bo, what you're telling me then is that there is a period there where you feel better when you're in alignment, which would mean that it's just fine what you described. I had thought that you weren't really getting any improvement at all from that. Aaron, have you seen body-wide muscle atrophy in CCI cases? Generally not, Aaron. I would go for other causes there like ALS or other things. Generally have not seen body-wide muscle atrophy in many CCI cases. Okay, guys, I'm going to start wrapping it up for today. Thanks so much for watching, and I will see you next week. And then the week after that, I'm off because I'll be in Grand Cayman seeing patients down there. So have a great week. Thanks for all the great questions, and same bat time, same bat channel next week. Thank you.